Radio dreams. All right.
Dude, they're so. I was driving. I was like,
A team approach to healthcare.
they had like a bed.
Supporting and setting up your ALS partner. This afternoon, we're going to learn how to set up a cardiac monitor. We're going to learn how to set up run flow rates with an IV. Then we're going to learn how to set up endotracheal intubation. These are all skills of the EMT. Now, the cardiac monitor we're going to show you is an outdated cardiac monitor. We haven't updated the videos, but the premise still holds true. It's kind of like switching from military to civilian. The values are still the same. What you do is still the same. The color coordination is still the same. The physical monitors generally aren't used. That's what we've done.
Hi, I'm Russ Hall. I'm the EMS coordinator for the whole fire department. I'm just going to go through the difference between ALS level ambulance and the department's ALS level ambulances. As you can see over here, BLS ambulance is basically equipped with basic first aid equipment, bandages, oxygen supplies, ice packs, fluid to irrigate wounds, backboarding equipment, and different splits. To set up a BLS ambulance, you see that the equipment that we need to take into some of these houses, basically our what we call a first aid bag, which has a basic first aid equipment, an oxygen bag, which has a portable tank in it, and a semi-automatic or automatic external defibrillator, which EMTs can operate in case somebody goes into a cardiac arrest. That's pretty much the only equipment. If you're running a BLS ambulance, you can transfer between trucks. Will be those 3 bags. The rest of the stuff is standard and Massachusetts. Equipment, as you see here, we have a lot more than just a couple bags of equipment that we have to move around and stock the ambulance with. It's all required by Mass DPH. In our ambulances, we carry a Medtronic LifePak 12, which is a monitor which allows us to do 12 lead EKGs in the field. We can manually defibrillate somebody, put an external pacemaker on somebody if they need their heart is failing and we have to get their heart rate up. We have the ability to do automatic blood pressures with this and keep track of their vital signs. This is a sophisticated piece of equipment. Our ALS first in bag is much more in-depth than the BLS bag. It takes a kit to put an airway in somebody if they need by intubation, which is putting a tube down somebody's throat to breathe for them. We have IV supplies in there. We have supplies for diabetics. We have drugs, as well as routine first aid stuff. We also carry a drug box, which is full of all the required drugs from the state of Massachusetts to treat all the different illnesses. We have backup drugs, which we must carry. We have a CPAP equipment, which is also used for airway people with congestive heart failure. We can do that. It's a positive pressure airway and keep their airway open. So all this equipment is all part of the ALS package. Then we have to stock the ambulance with a certain amount of ALS equipment, which is really not transferable from truck to truck. It kind of has to stay in the vehicle. That includes spare IV catheters, spare syringes, spare fluids, carry a certain amount of IV fluid. Sets for the IV fluid, extension sets for the IVs, and we also have to carry different airway supplies. We have to have spare endotracheal tubes. We have to have spare meds. We have to have spare supplemental airways in case we have somebody that's very difficult to intubate. We still have to get an airway in them. We have to carry those on the ambulance, and then we also have another cabinet full of spare ALS supplies, which is all our spare monitor and cardiac supplies, spare electrodes, defibrillator pads. We have to carry spare batteries for the monitor in case we have a malfunction. We have to carry a spare cable for read cable that's on that cardiac monitor, we have to carry with us in case there's a malfunction or taking care of the patient. So the ALS portion of the ambulance is very in-depth. It's not really something that you can carry in a couple bags.
Right.
It's a lot of equipment, but it's necessary equipment.
Yeah.
So when we get to a call, we have the ability to do what we're trained to do, and our hands aren't tied to just do basic first aid.
Right. What's the value of having the new third ambulance be equipped for ALS?
Well, there's many reasons why you'd want to equip every ambulance the same way, because it's continuity throughout the whole department. We operate under a paramedic basic staffing rate, which means that we can run an ambulance out of here with one paramedic in it and one EMT rather than two paramedics.
Okay.
That would enable us, when both of our primary ambulances are out, if we have another call, if we get a paramedic that comes back to the station, that ambulance can also go out as a paramedic unit. It's also nice to have spare equipment. Right now, when we started the service up a year ago, we pretty much have the equipment, the two primary trucks. We don't have spare stuff. So if one of our monitors malfunctions, we're out of service with one ALS truck for the time for it to get repaired. It's nice to have spare equipment, basically, for a service, especially a service that does the amount of calls that we do.
Any questions? All right, cardiac monitors, critically important to be able to detect what type of heart attack and what artery is blocked. Being able to assist in putting the cardiac monitor on is critically important aspect of being an EMT. So we're going to go over how to do limb leads. Limb leads are exactly what they say they are. They go on limbs. There's 4 of them, 4 limbs. A lot of times you'll see paramedics and nurses not put them on the limbs, but they're limb leads. Then we go to the 12 leads, which are the 6 V leads. And how to program the data in so the hospitals know what kind of patient or who the patient is that goes with the corresponding EKG. So, limb leads. The white limb lead goes on the right arm. The black limb lead goes on the left arm. The left leg lead is red. It goes on the left leg. And the right leg is green, and it goes on the right leg. But one of the ways of remembering it is white goes to right, smoke over fire. Green's got nowhere else to go. Questions? Then you have your V leads. So V1 goes to the third intercostal space. That's between your third and fourth ribs. So above the fourth rib, below the third rib, just to the patient's right of the sternum. V2 goes to the opposite side of V1. Third intercostal space just to the patient's left side of the sternum. Not on the sternum, in the fleshy area between the third and fourth rib, just to the left of the sternum. Then we skip V3, we go straight down to V4. V4 goes at the midclavicular line, which is directly below the nipple at the fourth intercostal space. So if it's a person that's well endowed, you have to lift the breast up with the back of your hand, and you put V4 directly underneath there. Then you put V3 between 2 and 4. Then V6 goes mid-axillary line, fourth intercostal space. Then V5 goes directly between 4 and 6 in a straight line. Any questions? It's really that simple if you just got to memorize it. Any questions? All right. Now here's something we hope you'll really like.
To properly apply a 12-limb EKG to a patient. We're going to start off with the 4 limb leads. We normally put on the limbs, but of course our model here today does not have limbs. So we use the shoulder and this lower abdomen. We're going to take the right arm lead, which is white, and we're going to put it up right above the right shoulder there. We're going to take the left arm lead. We're going to put it right above. It's about clavicle and left shoulder there. And we're gonna take the left leg lead. If it doesn't have legs, we're gonna put it right above the pelvis on the pelvis, on the soft tissue there. And then on the equal opposite side, on the right side, we'll take the green one, which is right leg lead. Put it right there. Now we're ready for our V leads. First thing we have to do is we have to hook up the 12 lead cable. Now you notice there's a cap that goes into that. Cap's critically important because the pinholes in here and the pins are extremely fine and delicate. So if any dust gets in, they get bent, they break, and then the entire cable doesn't work, which is also a very expensive mistake. So as soon as we unplug a 12 lead cable, we always plug the cap back in immediately. We want to leave this open air as little as possible. So plug our 12 lead cable in. And we start with our V1 lead. Our V1 lead is a red lead. We put it on the third intercostal spot, just right of the sternum, above the nipple line. V2 is our next lead, it's yellow. We put it on the opposite side of the sternum, V1. Then we take V4. We actually skip over 3 and go to V4. V4 is a blue lead. And we're going to put that at the fourth intercostal space, which is just below the nipple, which also happens to be mid-clavicular. Next one we're going to take is V3. V3 is going to go directly between V2, V4. Our next lead is going to be V6, which is purple. V6 is going to be at the fourth intercostal space, same line as V4, straight over to the mid-axillary line, which is the center of the armpit. Our last lead that we're going to put on is V5. V5 is orange. It's going to go halfway between V4 and V6. You've now successfully applied for the UKG.
Question.
So why is it called a 12 lead if there's only
10?
10?
There's 2 of them do double duty. They work both ways.
Oh,
Yes.
I see.
All right, printing a strip, you hit the record button, it'll print the strip. No matter what button, no matter what monitor or brand you're using. All right, so programming the monitors. There's going to be, like I said, this is an old out-of-date monitor, but they're all pretty much the same. You're going to go to the patient info button. You're going to select the gender, which is very important because the different algorithms of how it recognizes it is based on gender. They're going to enter the age, which is also very important because there's different algorithms that the monitor reads the rhythm for different ages and different genders. And then lastly, you're going to put in the patient's name. Last name first, first name initial, first initial. That way, when you have a hospital that's getting multiple 12 leads from multiple ambulances, they know which one goes to which patient. Very, very, very important. Any questions? So I got some how-to videos coming up here. Then when all that's done, then you hit the acquire button. You have the patient hold as still as possible. You're not allowed to hit the acquire button. You can do everything up to hitting the acquire button. But the paramedic can only hit the acquire button. Then they'll send it. They'll ask you which hospital you want to send it to. Then it'll send it over the internet to the hospital. Any questions?
Okay, so what we're going to do here is learn how to obtain and transmit a 12 lead EKG using a Zoll E-Series monitor. So the first button after we hooked our patient up to the 12 lead, we're going to push this 12 lead button. And that'll bring us to the 12 lead monitor screen. The next button we want to push is the phone. Your 12 lead will be acquired. And at that point, you'll want to decide which hospital to send it to for your choice of hospitals. You can use the arrows on top of the monitor, up and down, to select which hospital you want to send it to. Now all you have to do is hit transmit now button. You will see we'll go through a series of screens retrieving the record. At this point, it's completely automated. All you have to do is keep the phone within a short distance of the monitor. About 10 feet.
This is the old, this is 2 generations
And it'll
ago.
take care of all this for
The
you.
newest Xers are like a quarter of the time. They're always on Wi-Fi. As long as you have a hotspot, they're always on Wi-Fi. They just boom, send it. It's gone. Send it anywhere in the world, directly to the doctor's cell phone. You can send it anywhere you want to send it. Even the old ones, you can do that.
And the transmission is
It
clear.
could also be because
Transmission
of Trinity,
is
there's
complete,
so
which you may
few
not even
cellular
notice
spots.
until you're working on your
You may
patient.
not have the
And you have successfully
the ability-
taken and transmitted
Pretty normal.
12 EKG. Thank you.
because this only works when you're in cell range.
Struggle with our repeater.
Yeah, this only works when you're in cell range. If you're down the river by Happy Camp and stuff, this ain't gonna happen. You got any in? Huh? Yes.
Action. Can't see your face, it's just a glove. Go ahead and explain what you're doing if you're doing it. Right arm lead to the right arm, left arm lead to the left arm. Right leg lead just above the right leg. Left leg lead just above the left leg. V1, counting the rows down. 1, 2. Use the back of your hand. Lift the breast up. I'll be holding up. Perfect. Always use the back of your hand. It's never appropriate to top a field. Inappropriate.
YouTube hasn't taken this one down. Copy the field. V6 is the mid axillary.
Well,
To Mercy.
Mhm. Just the 12 lead button. No. Push hand up.
do you have to have an operator's card in
Sorry,
that one
no.
for it to work or something?
How old are you, sir?
Got a modem card. Yeah.
That old, 28 modem.
No, I mean, it's Wi-Fi. You can use Wi-Fi. Or actually, I'm sorry, you have to have a modem card if you're gonna hook it directly into a landline. Other than that, it's got Bluetooth that just connects to the Bluetooth on your cell phone.
This one does?
Yeah.
Oh. I didn't know Bluetooth was invented.
Dude, how old do you think that technology is?
Back to about 2004, 20 years.
That was when I was born. So,
You're younger than Bluetooth, my friend.
Bluetooth's been around forever.
Really? Learn something different.
Since the 80s. I do. The king. Bluetooth.
I was sure be a question of a bar.
So,
You wanted to bring all the kings together, kind of like Brian Brew.
1994, the invention of Bluetooth.
I lied, it was in the 80s. Weren't being a smart
At
ass,
this point, you can walk away from it.
potentially bagling himself.
You'll see though. You'll see the transmitting.
Oh, see that.
so you don't go put them on the shoulder for less artifacts?
Yeah, sometimes it just depends on how much hair they have and how much access I have. Then I just put them up with a clavicle, because how much meat's on the patient.
What if they?
Artifact. It's artifact.
Yeah, how do those work with a lot of chest hair?
Shape.
You gotta shave it.
You're gonna get a shave today.
Or just take Gorilla Tape, put Gorilla Tape on first and then pull. Good way to check for level of responsiveness. They're unconscious.
Wait, catch it right to the left.
All right, any questions on EKGs?
So he mentioned the artifact thing. That-
Yeah, just a sec. Question.
So is there an amount of meat that's too much meat to register on there, or is it just always like?
It's always there. As long as there's water and cells, the positive and negative signals will go through. So artifact's a problem. So if your electrodes are too dry or your patient's moving around, you'll get artifact. Or if there's hair. So what you gotta do is try to shape them as much as possible, hold still, and make sure you have fresh.
I
Louis
saw a
electrodes.
paramedic when he put the 12 leads on and ran them. He asked the driver of the ambulance to slow it down quite a bit for a second.
Yeah, just so you get the 12 links. You don't want artifact on the 12 link. Cause misreadings.
Does that go for like immediate connections, or is the
Yeah.
artifact something that just kind of comes up in general?
Artifact comes up, like I said, when there's movement or not a good connection.
And how does that look like? Or what
It's
does
like V-fib, it's a squiggly line. So find and it's 60 cycle, which we don't see much anymore because the modern monitors filter it out. The 60 cycle used to give really good artifact.
You have something wild like. Wow. Okay.
Yeah, the guy that was on the 12 lead for us, he looked like a seismograph. He was not.
Grammarly's top 3 tips on starting an essay.
Let's say you're struggling with pen.
That's what artifact looks like.
And that's from.
Yeah.
I'm just gonna show you what, see if I can get some faces here.
The guy's shivering, he's so cold.
So that's what's causing the artifact.
Shivering.
So do you feel cold at all? You're just shaking.
Beetle song. Just reach out.
That is a perfect question.
Sorry, Rob. All right, any other questions on ECGs? Be familiar with the ones you'll be interfacing with. Most of the ones here in Siskiyou County are X series, with the exception of Cloudfire that has a life back 15. All right, IVs.
Okay, so for
You can spike IVs, have them completely set up, you just can't put the needle into the skin.
today, I'm going to be just demonstrating on how to set up an IV. So the things that you want are some IV tubing and a bag of normal saline. And you've probably gone through your rights by now and making sure that it has a good expiration date. Nothing is in the bag and everything is still sterile technically. So what we're going to want to do is take your bag of saline. And there's little notches at the top. Just rip it along the top like that. Now this is your administration set. So tear it down just like that. Try and keep everything bundled up because it will make things easier. You're going to want to lock your IV tubing down. And there's a cap on top of the drip chamber right here. Pop that off, throw it away. And there's a blue top tab right here on the saline. And I want to pop that off. And with the bag upside down like that,
You can hold the right side up, there's a membrane.
insert your administration set in. Turn this upside down. Fill up your drip chamber by squeezing it like that. And trying to maintain sterility. Don't let your tab hit the floor. So we're gonna open it up just like that. Gonna open your IV tubing up and see how it's dripping at the very bottom. That's good. We want to extract all the air bubbles. And once you're ready, close it off and hang it up and administer to your patient.
Any questions? That's all there is to it. It's nothing difficult. Just don't want air bubbles in the line. All right, IV setup. And you can do all this until you don't puncture the skin.
IV access to a patient provides us with one of the most direct routes for patient treatment. Fluid and medications can be immediately introduced into the body through the circulatory system when performed correctly, and it can be one of the safest, most effective methods. An important point to remember is making sure you prepare all the necessary equipment and supplies before you begin. Sharps container, tape, or another securing device for securing the IV, antiseptic swabs per your local protocol, gauze pads, site dressings, a latex-free tourniquet, appropriate size catheters, of course, based on your patient's needs, and a Band-Aid. Your preparation in advance will help you achieve a safe and sterile intravenous catheterization.
IVs have to be sterile if you do not want them to reproduce.
Select the appropriate IV solution, double checking the expiration date, color, and clarity. Administration sets generally come in two sizes, 60 and 10 drop sets. The appropriate size is determined on your protocols and patient's medical condition. To open your solution, tear the outer packaging at the pre-cut slit on either end of the bag. Recheck the clarity of the solution and expiration date. Whenever possible, the IV bag should be hung in a vertical position with the tail ports extended downward to facilitate the preparation. Open the appropriate administration set based on the patient's condition. Be certain that the end caps remain in place to preserve the sterile field of the administration set. Uncoil the tubing in preparation for spiking the IV bag. And if adjunct devices, such as extensions, are to be used, it should be opened and attached to the administration set at this time. Move the flow control clamp to the closed position and place it in a convenient location. Grasp the IV port just above the plastic tab, and with the other hand, pull the plastic tab from the port, being careful to maintain sterility of the port itself. Remove the protective cap from the IV tubing spike and insert the IV tubing spike into the IV port by pushing with a twisting motion until the spike punctures the seal of the port. Squeeze the drip chamber to fill it approximately half full of fluid. Open the flow control clamp and allow the IV fluid to completely fill the line. It's often necessary to invert or flick the med ports to remove larger air bubbles. Once the line is completely filled with fluid, close the flow clamp and place the primed line in position for use. A second method for spiking an IV bag consists of inverting the bag so the tail ports extend upward. Grasp the IV port just below the plastic tab, and with the other hand, pull the plastic tab from the port. Remove the protective cap from the IV tubing spike and insert the IV tubing spike into the IV port by pushing and twisting the spike until it punctures the seal of the port. Invert and hang the bag so it's in an upright position. Squeeze the drip chamber to fill it approximately half full of fluid. Selecting a venipuncture area usually involves the hand, wrist, forearm, or antecubital space. Inspect it for contraindications for venipuncture. Applying a venous tourniquet may help facilitate finding the appropriate site. When selecting a vein for cannulation, it may help to reapply the venous tourniquet approximately 4 to 8 inches above the selected area. Cleanse the intended venipuncture site with a suitable antiseptic swab in an outward motion for at least 2 inches. Allow the alcohol to dry for 30 seconds for bacteria to be killed and to minimize the discomfort to the patient. Based on the intent of the IV and the size of the vein selected, choose an appropriate size IV catheter. Remove the catheter from its packaging and the protective sheath. Remember to be careful to maintain the sterility of the needle and the catheter and visually inspect the end for any defects, such as burred edges. As an optional step, slightly twist the catheter to ensure the catheter moves freely on the needle. Grasp the patient's extremity near the area where the IV will be started using your non-dominant hand in order to stabilize the vein. This may be accomplished by either pulling traction distally or holding the extremity circumferentially so the area is taut. Ensure that the bevel of the needle is facing upward in relation to the patient's skin. While continuing to apply traction to the skin, quickly but carefully enter the skin with the needle. A pop may be felt as the needle enters the vein. In this alternate view, the flash chamber fills with blood when the needle enters the vein. Slowly advance the catheter along the needle until the hub meets the patient's skin.
You're not allowed to do that.
Palpate the end of the catheter beneath the patient's skin and occlude the vein with direct pressure.
Attach IV tubing to the catheter hub, making sure not to push the catheter further in or pull it out. After releasing the tourniquet, open the IV flow clamp and observe the flow of fluid into the drip chamber. With the IV running and before securing the IV in place, inspect the venipuncture site for signs of infiltration. If an IV cannot be made to flow properly or infiltration is observed, discontinue the IV immediately. If the IV is observed to flow properly, using a gauze pad as necessary, wipe away any fluid or blood that may be present in order to dry the site sufficiently that tape will adhere. Secure the IV and the IV tubing in place. Cover the insertion site with a sterile dressing or a commercially available device. Many taping methods and commercial securing devices are available, but follow your local protocols. Adjust the flow rate by closing the flow clamp or other flow metering devices to the appropriate setting, and continue to monitor the patient for signs of fluid overload, other complications resulting from the IV, maintain the appropriate flow rate, and watch for infiltration. Some protocols may require you to initial and date the IV cannulation.
Not allowed to do this either.
Selecting a venipuncture area
But
usually
yeah,
involves
they
the
tell you
hand,
peripheral blood draw, you
wrist,
gotta know how to set it up.
forearm, or antecubital space. Inspect it for contraindications for venipuncture. Applying a venous tourniquet may help facilitate finding an appropriate site.
But if you were to do it, you get this right here, it's called a vacutator set up. That's gonna plug into the IV site, then you get the colored blood tubes that they ask. It's to try to get labs done faster for critical patients. You draw it in the field when you're already getting an IV, it saves a lot of time.
When selecting a vein for cannulation, it may help to
This would be
reapply the venous
AJ,
tourniquet approximately
requiring
4 to 8
electronic healthcare
inches
records,
above the
hospital
selected
scanning
area.
in the field. So that's why we don't do it anymore.
Cleanse the intended venipuncture site with a suitable antiseptic swab in an outward motion for at least 2 inches. Allow the alcohol to dry for 30 seconds for bacteria to be killed and to minimize discomfort of the insertion.
Got that kind of time, it's not an emergency IV.
Based on the intent of the IV and the size of the vein selected, choose an appropriate size IV catheter. Remove the catheter from its packaging and protective sheath. As an optional step, slightly twist the catheter to ensure the catheter moves freely on the needle. Hold traction distally or circumferentially so the area is taut. Ensure that the bevel of the needle is facing upward in relation to the patient's skin. While continuing to hold and apply traction to the skin, quickly but carefully enter the skin with the needle. A pop may be felt as the needle enters the vein. The flash chamber should fill with blood when entering the vein, but remember, patients with poor perfusion and small catheters will be slower to show a flash. Slowly advance the catheter along the needle until the hub of the needle meets the patient's skin. Palpate the end of the catheter beneath the patient's skin and occlude the vein with direct pressure. For blood draws, leave the tourniquet in place. Apply the vacutainer to the catheter hub and use the flanges on the container to facilitate pressure when inserting blood tubes. Secure the vacutainer while switching blood tubes, and after each blood tube is drawn, gently mix the tube. However, follow your local protocols on blood draws. After releasing the tourniquet, palpate the end of the catheter beneath the patient's skin and occlude the vein just proximal to the end of the catheter with direct pressure. With your free hand, remove the protective cap from the end of the IV tubing and attach it to the catheter hub, making sure not to push the catheter further in or pull it out. Open the IV flow clamp and observe the flow of fluid into the drip chamber, commercially available device. Shut off the flow clamp on the nearly empty IV bed, the outer packaging by tearing the Select and inspect the IV solution. Open the outer packaging by tearing the pre-cut slit at either end of the bag. Check for clarity and the expiration date. Shut off the flow clamp on the nearly empty IV bag to prevent air from entering the IV tubing as the solution bag is being changed. Invert the empty bag to prevent any remaining fluid from running out, then remove the IV tubing spike from the bag, using extreme care to ensure the IV tubing spike does not touch anything to contaminate the sterile field. Follow the methods previously described to puncture the new solution bag. Discard the used solution bag after noting the approximate amount of fluid remaining, if any. Finally, reestablish the IV flow rate.
You're not allowed to discontinue an IV.
When discontinued,
All right, however, you are allowed to monitor IVs during transport. Yes,
What are the contract
for IV insertion.
locations? I think I'm saying that, like observe for contraindications.
So you can't do it through an infected site or on through a burn or anything like that. Can't do it like you do a fracture, you know. Says affected, other than that, there's no real kind. If it's a diabetic, you shouldn't do it in their feet, because they have bad perfusion there, so it's hard for it to heal. If it's an emergency, you'll still do it. So there's the formula for being able to run IV drip rates. I don't recommend you use it. I recommend you use the brand formula, which is much better. But this is the formula I have to teach you today. I doubt it if you have a test, but you never know. It's my formula. I believe you should be able to do everything in your head without having to write things down. So I think it's that you're taking the desired dose. Let's say you're running an IV, you're told on a transfer, you run 100 milliliters an hour. Okay. So if it's 60 drops per milliliter for your tubing, it means every 60 drops is 1 milliliter. You just add a 0 to it, correct? It's 100 an hour. So that's 600 an hour. So how many drops? 600 an hour over 60 minutes. How many drops per minute is that? 600 divided by 60. 10 drops a minute, drop every 3 seconds. Much easier. That's why I use 60 drops, because it's easier to calculate for hours and minutes. Let's give an example. All right, say you're running 10 drop tubing. So you got to go to 150 an hour. That's 1,500 drops an hour. Right? 1,500 divided by 60 is 25 drops a minute, or a drop every other second. Every 2 seconds. This is really difficult stuff. It's as hard as you make it or as easy as you make it. Questions? Let's do another one. We're going to do 100 drops an hour at 20 drop tubing, because you don't always have access to 60 drop tubing. So 100 drop tubing at 20 drops per milliliter, that's 2,000 drops an hour. 2,000 divided by 60 is 34 minutes, 34 drops a minute. So again, about a drop every other second. Questions? Nurses can no longer do any of this. There's not a a nurse out there, because over the last 25 years, everything nurses do is pumps. The pumps do everything for them. In the field, you're not going to have that. It always cracks me up when we're doing a transfer and we disconnect a pump to go out of the hospital, and you'll have a charge nurse that's in charge of the whole hospital. She'll say, "Do you need a pump for that?" And the EMT will say, "Nope, it's 30 drops a minute. I already got it. It's drop every second." They go, "How did you do that math in your head?" So I go, "Well, they go through what they did here in class. It's not that hard." Any questions? All right, intubation. Endotracheal intubation is a paramedic skill. This is a skill, or instead of using an eye gel that goes down the point and plugs the esophagus and seals the oropharynx, an endotracheal tube actually goes between the vocal cords, then inflates the cup internally between the vocal cords. It's a much better airway. It's also much more dangerous because if it accidentally goes to the esophagus, it ventilates the stomach and kills the patient. So this is a critical high-end skill, but paramedics need help setting it up. It's much faster if the EMT assists the paramedic in setting it up.
Okay, guys, what we're going to do right now is just go over a bit of the equipment that you're going to require for airway management. First and foremost, I think it's imperative that if you are the one doing the intubation, it's your responsibility to actually check your equipment. Assemble it, check it, and be sure of the operation so that when you are actually doing your intubation, you know if anything is working properly or not. The setup of equipment is going to be, first off, collecting everything that's going to be required. So you can always do this while your patient is pre-oxygenated if it's not an emergency situation, or even prior to if the patient has arrived, if you know preemptively that you're going to do some intubation. First thing you're going to get for yourself is a resuscitation bag. I always do a quick check on my bag to make sure that it's actually holding pressure. I include the end, push on it to see if the pop off goes off, close the pop off, want to squeeze to make sure it's holding any kind of pressure. And we can even do a negative pressure check on this, but I'll show you that in the lab if necessary. Next thing I'm going to do is look at my actual instrumentation for laryngoscopy. So you're going to need a handle with operating batteries, a blade that actually fits the handle. So I'm using a standard handle, standard blade here. This is a Mac 3. I'm going to actually make sure the bulb is nice and tight on the distal tip. Flip it on and check that the light is actually working and that it's bright to your satisfaction. I have a number 4 blade if I was unsure of the insertion depth, so I can also check that. Look at the bulb, tighten it, make sure that it's working appropriately. I'm going to leave the number 3 blade on because that's the most common one. I'm going to leave it in the disengaged position. Next thing I'm going to do is check my endotracheal tubes here. So I've got a number 7.5 and a number 8 for my adult patient here. So I'm going to pair both of these. What I'll do is I'll get a cuff inflator. And while it's in the package, generally what I do to kind of keep it clean is I'm going to insert a couple cc's, probably 10 cc's or so of air into the cuff and make sure that it's holding pressure. So we'll insert, and basically I just squeeze on the cuff to ensure that it's actually holding. You want to deflate all that air all the way back out so that when you are using that tube, it's not going to cause any kind of obstruction of your view or have difficulty going through the cords itself. So I would do that with both tubes. Next thing I would do is look at getting the stylets. Stylets are great to assist for any kind of intubation attempt, especially if you don't know if the larynx is anterior or not. Lubrication is going to be a good idea to just slightly lube up the stylet. You can use some gauze. And very briefly, or sorry, very slightly, you can lube up the distal tip of the endotracheal tube as well. Thinking ahead to basic airway management, I want to get some Goodell airways ready so that my bag mask ventilation will be more effective and I can always achieve oxygenation and ventilation. I've got here an end tidal CO2 clip that's going to go on the end of my endotracheal tube once I've performed my intubation, hopefully detecting the presence of carbon dioxide, indicating that I am in the trachea. I'm going to get some securing tapes ready, and we'll go through how we secure an ET tube. And finally, I want something that may be used if my intubation attempt fails. It's always a good idea. I always have an LMA on hand, or at least a quick reach so that I know where this is if my intubation is going poorly. I can have something to reference quickly. You may also want to grab a number of different masks if you don't know the size of your patient that may be adequate for bag mask ventilation. And you want to prepare your PPE as well. CRTO guidelines say that for any intubation attempts, we're going to be using gloves, mask, and eye protection, so goggles. You're going to do your own risk assessment as well to identify any other hazards that you may want to take extra precautions against. Okay, so now we've checked our equipment. The next thing we're going to do is move on to our patient, preparing our patient for intubation. First and foremost, verify that we have proper oxygenation. So if your patient is spontaneously breathing and non-rebreather, so close to 100% oxygen, as close as we can get on a flow meter that's 15 liters per minute or flush is adequate. If they're not spontaneously breathing, that's where you or your assistant is going to have to manually ventilate them for a minimum of 8 to 10 vital capacity breaths with your manual resuscitator, possibly even looking at your saturation until you've optimized the situation. It's very important that you can establish nitrogen washout and pre-oxygenation prior to an attempt. Positioning your patient, you're going to want to put them into that sniffer's position. So extend the neck a little bit, do the chin lift. If required, you can use an assisted roll to help get your patient into that alignment so the pharyngeal and laryngeal planes align. And lastly, you want to look at your operation of intravenous and your monitors. So it's very important we have a working intravenous so that we can give our pharmaceutical agents that are going to help us with our induction and possible paralytics for intubation ease. ATS criteria says at minimum we want 3D ECG, non-invasive blood pressure, and a saturation probe that you can see we've got on our monitor here. Once you've prepared all of your equipment, you've prepared your patient, and you're satisfied with the operation of your intravenous and your monitors, at this time it's appropriate to prepare everybody else who's going to be your assistant for the intubation attempt. It's usually a physician, a nurse, and a respiratory therapist, and the roles will be delegated or assigned prior to, and be very informed of what your role is and what you're going to do as either the intubator or as the assistant.
Any questions? What's that exciting?
Really.
Riveting? That was the frog set. Wait, no, that was riveting. That's killing the knee. Yes. All right.